Okay, well, I hope you're not feeling under pressure today, but that is what we are talking about in this episode. So this is all about blood pressure. So blood pressure is the force per unit area exerted on a blood vessel wall by the blood contained within that vessel. And so we are really, when we talk about blood pressure, we're referring to pressure in the arteries, because that's where we're taking our blood pressure, and it's going to be measured in millimeters of mercury. So blood pressure is two numbers. So you have a top number and a bottom number. So that top number is the systolic pressure. So when the ventricles contract, the left ventricle is going to eject blood, and that blood is going to exert 120 millimeters of mercury force against that vessel wall. And then when the heart relaxes, because of those elastic arteries and that recoil, we still have pressure, and that's called the diastolic pressure, and set point for an adult is 80 millimeters of mercury. And then we're going to talk about mean arterial pressure, and that is basically the average pressure to deliver blood to the vessel. So we need to take an average there. Here we go, this is better. So mean arterial pressure, average pressure of the blood in the arteries, the average force that propels blood to the tissues. Okay, remember when we talked about the cardiac cycle and we said that the heart rests longer than it works. And so the vessels have pressure in them. Only about 40% of the time is that systolic pressure, and then about 60% of the time is that diastolic pressure. So you just can't take the middle point between systolic and diastolic. And so that's called mean arterial pressure. And so you take the lower number, diastolic pressure, plus 1/3 pulse pressure. Okay, this word pulse pressure is the pressure of a pulse. So it's going to be a difference between systolic pressure and diastolic pressure. And so that's really what you're feeling when you feel someone's pulse. And this is the measurement. If you've ever been in a hospital and you look on a monitor, it's MAP that's also being monitored. Yes, you'll probably see BP, you'll see heart rate on that monitor, but you're also seeing mean arterial pressure. 70 to 110 is normal for mean arterial pressure. 60 is the minimum required for organ perfusion. So if this drops, mean arterial pressure, if it's below 60, that means there is not enough pressure to make sure that organs get blood. If they don't get blood, then you get organ failure and death. So you don't want to see it drop. Okay, so I'm going to give you some practice. Go ahead and calculate mean arterial pressure. Hopefully you got that right. Just a little practice using that formula. When you measure someone's pulse, you're just feeling that alternating expansion and recoil, and once again, it's always going to be in an artery. And so when you feel that bump, that is one heartbeat. And so you can get heart rate by feeling someone's pulse. And so the average heart rate is about 75 beats per minute. Of course, it varies. The acceptable range is 60 to 100. Remember, a heart rate below 60 is bradycardia. A heart rate above 100 is tachycardia. Once again, we're talking at rest. Those pulse points, most of the time arteries are going to be deep. Remember, because if you cut an artery, you get that spurting of blood, and we don't want that. We don't want to lose blood. So there are places in the body, though, where an artery is going to be superficial, and usually we need it superficial by a bone so we can palpate it and feel that pulse. And so you have all these pulse points are on your lab list for this week. So this is the backside of that study sheet. Once again, I highly suggest print it and study this sheet. And so we're just going to go through all these parameters that affect blood pressure. Yep, so I've given you a formula. So what blood pressure is, it equals cardiac output times peripheral resistance. And so the abbreviations, BP is always going to mean blood pressure, CO is cardiac output, peripheral resistance. So heart rate and blood pressure, they're going to be controlled through the autonomic nervous system for short term, and then we're going to add our endocrine system is going to control through blood volume. So let's talk about the nervous system control first. And I just always like the big picture. So remember, nervous system, sensory information goes in. We've got our integration center, which since we are always talking about autonomic functions, today it's going to be the medulla, the magical place, the medulla, in the brainstem. And then we have motor output going to cardiac muscle and smooth muscle, those effectors. And so the goal of the cardiovascular system is to provide all tissues with an adequate blood supply. And so in order to do that, we need a proper heart rate and blood pressure. Just reminding you of the two branches of the autonomic nervous system. So most of the time, life is not that exciting. I know, it's sad. So parasympathetic nervous system, remember the little tag for that was rest and digest or feed and breathe. So this is the system that's in control most of the time. It is focused on housekeeping and conservation of energy. So parasympathetic innervation is going to lower heart rate and lower blood pressure. And think of this picture, the blood is going to go to the abdominal organs. We're going to be digesting our food, we're going to be filtering our blood, removing waste. So those sort of housekeeping functions. Pop over here, occasionally life gets a little exciting. So the sympathetic nervous system is going to take over for that fight or flight response. So I taught my students the 3 E's. So during emergency, excitement, or yes, exercise. This is the branch that is concerned with saving your life. So in this case, we're going to increase heart rate and increase blood pressure. So parasympathetic, we're going to lower heart rate, blood pressure. That's through acetylcholine. That's the neurotransmitter of that system. And then heart rate and blood pressure are going to increase with norepinephrine. And of course, we get that release of epinephrine from the adrenal medulla. Okay, so that sensory information coming in. If we're talking about the regulation of blood pressure, then we need to monitor that. And so that is the job of baroreceptors. So baroreceptors are going to detect arterial blood pressure by responding to stretch in the vessel wall. And you have 2 locations where this is being done. One is in the aortic arch. There are receptors in the wall of the aorta, and it's going to send that information through the vagus nerve, so cranial nerve 10, to the medulla. Then, I don't know if you've looked at your lab yet, so the vessels. We are going to have the common carotid arteries, so going up alongside the neck, and then they bifurcate, so they split. The external carotid is going to deliver blood to the side of the neck and the head, and then we have this internal carotids. They are going to the brain. So that's a great place to monitor blood pressure, and that is going to be called the carotid sinus. So this internal carotid artery just sort of has this little place where they are baroreceptors. And so that's going to be cranial nerve 9. The glossopharyngeal nerve is going to send that information in. So monitoring systemic blood pressure and monitoring that blood pressure specifically going to the brain.
Increased blood pressure stretches the carotid arteries and aorta, causing the baroreceptors to increase their basal rate of action potential generation. Action potentials are conducted by the glossopharyngeal and vagus nerves to the cardioregulatory and vasomotor centers in the medulla oblongata. As a result of increased stimulation from the baroreceptors, the cardioregulatory center increases parasympathetic stimulation to the heart, which decreases the heart rate. Also, as a result of the increased stimulation from the baroreceptors, the cardiovascular center decreases sympathetic stimulation to the heart, which decreases heart rate and stroke volume. The vasomotor center decreases sympathetic stimulation to blood vessels, causing vasodilation. The vasodilation, along with the decreased heart rate and decreased stroke volume, bring the elevated blood pressure back toward normal. If the initial problem were a decrease in blood pressure, the activities and effects of the baroreceptors, cardiovascular center, and vasomotor center would be the opposite of what is illustrated.
All right, so we have this information coming in, so through those carotid sinus and through the aortic baroreceptors. And so they're going to send that information to the cardiac control center and the vasomotor center. So we have 2 ways for that short-term regulation of blood pressure. We can affect heart rate and the heartbeat, or we can affect the tension in the blood vessels. And so I'm going to give you this analogy that your heart is like a car, and so there's the gas and there's the brakes. And so the brakes are going to be the cardio-inhibitory reflex center. So that's going to lower heart rate. The gas pedal is going to be the cardio-acceleratory reflex center. That's going to increase heart rate, but it's also going to control how intense that heartbeat is. So that's called contractility. That vasomotor center, so vessel motor, so smooth muscle, is going to redistribute blood flow to profuse organs. So when you're relaxing, so rest and digest, it's going to go to the viscera. When you're exercising, it's going to go to the skeletal muscles, the heart and lungs. And then it can also control that tunica media, that smooth muscle, to control the diameter of blood vessels. So everything that we just watched. How those baroreceptors are doing it, they, just like we watched, they are going to send a series of action potentials. And so when the blood pressure increases, they increase that frequency. Because remember, an action potential either gets sent or it doesn't. It can't be like a bigger action potential. So the way the nervous system runs is if it really wants to like say something, like it can't increase its volume. So it's just going to increase the rate of those action potentials. So that's how the cardiac center and those vasomotor centers know. If there's a lot of action potentials, that means blood pressure is high and it needs to be lowered. There's not enough action potentials, that means BP is low and it needs to be raised. And so it can control that by controlling heart rate, contractility, and also that either vasoconstriction or vasodilation. So here, I've given this to you. I like this picture. It's in your notes. It's just kind of nice and easy. Just everything we just watched. Increased blood pressure, increased baroreceptor firing. We are going to increase the brakes, so cardiac inhibitory center. We're going to lay off of the gas, the cardiac acceleratory center, and then we are going to dilate those blood vessels. And so that's going to drop our pressure, bring it back to homeostasis. If the blood pressure is too low, there's not it's too few action potentials being sent to the vasomotor center and the cardiac center. And so we are going to lay off of the brakes. We're going to push the gas to the cardiac acceleratory center, and we are going to do vasoconstriction, because when we constrict, we are going to increase blood pressure and restore homeostasis. So that's how the autonomic nervous system is responsible for short-term control. This is some verbiage for you. I'll leave that for you to read. I'm going to talk about it through a picture. Like I said, I like to do pictures, but hey, guess what? This is you. That's your heart right there. It's a sweet ride, isn't it? I'm currently car shopping. I'm not getting this. That is not what I can afford. All right, so let's look at this picture. So this is showing you a cross-section through the brainstem, the medulla oblongata, or just called the medulla. And so see these darker areas, these are nuclei, so they're clusters of neuron cell bodies. And so there is a center for raising heart rate, so the excellatory center, so right here, and then there's a center for inhibiting it. There's also a vasomotor center there. So let's look at our brakes first. It isn't exactly like a car, so hopefully when you drive a car, you have your foot either only on the brakes or on the gas. Your heart kind of rides the brakes, if that makes sense to you. All right, so it is going to be the vagus nerve, and notice where it's going. So here we have motor output, and so let's follow this one. Sympathetic trunk ganglion, yeah, wasn't that fun? Preganglionic fiber, postganglionic fiber, for parasympathetic to be close to the organ. But I want you to notice where it's innervating. It's innervating our SA node, which was the pacemaker, and our AV node. And so this is responsible for controlling heart rate. And so parasympathetic is going to lower it. Pop over here. So now let's look at the gas. So let's look at the cardiac acceleratory center. And so here we've got, it's going down the spinal cord, and then we've got another neuron, and then we've got that sympathetic trunk ganglion, but I really want you to see where it's going. It's going to the SA node and the AV node, so it can increase heart rate. But look what's different. It's sending fibers to the myocardium. So the sympathetic nervous system is going to raise heart rate, but it's also going to increase the force with which that heart is ejecting blood. So it's going to have a stronger heartbeat. And you know this, when you're excited, you can like feel your heart beating in your chest. Most of the time, like I said, life's pretty boring and you can't feel that. How it's accomplishing this. So let's look at parasympathetic first. Remember, it's talking to the SA node and the AV node. And this was our pacemaker action potential. And I gave you this analogy of that big bucket. And so those SA node, the AV node, it never has a stable resting membrane potential. And remember, it's like a leaky bucket. So we're constantly leaking, drip, drip, drip. Sodium ions are coming in and getting us closer to threshold. So remember, that was the goal. Because once you get to threshold, then you get depolarization, repolarization, we're getting a heartbeat. So just like this bucket, drip, 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 once it's full, it reaches threshold, it dumps. So what parasympathetic innervation does through the release of acetylcholine is it's going to open potassium channels. So remember, if potassium goes out, that makes those pacemaker potential more negative. So it's going to be farther away from threshold. So it's kind of like having a bigger bucket. We're going to have to drip more sodium before we get to threshold. So we're going to get decreased heart rate. So here we go. So normally your heart, which is why I said you are this beautiful car right here, a sports car, the intrinsic conduction rate of the SA node is about 100 to 110 beats per minute. So it's shown by this black line. So inherent SA node pacemaker activity. So boop, boop. So that would be a faster heart rate. What happens with parasympathetics with acetylcholine, we've opened those potassium channels. So look, we are starting below, lower. We've lowered that resting membrane potential. And so it takes us longer to drip and get to threshold. That's all. And so I'm just kind of showing you, it just decreases the slope. So that's going to slow heart rate. When this is going to come into play, and why I'm doing this, is when you take pharmacology, drugs that block acetylcholine binding, for example, atropine is a really common one, can increase the heart rate. So if someone comes in with bradycardia, they give some atropine, and that is going to then increase heart rate by blocking acetylcholine. Because like I said, your heart kind of always rides the brakes. So you always get both sympathetic and vagal talking to the heart at the same time. So that's what's responsible for vagal tone, because parasympathetic through that vagus nerve. How the sympathetic nervous system works is it is going to work by moving calcium, by opening calcium channels. So norepinephrine binds to those beta-1 adrenergic receptors, and we get calcium moving. Remember calcium, so we're going to get calcium coming into the cell, so we're getting more positive, closer to the threshold, right? So that's one thing it does. It also phosphorylates the sarcoplasmic reticulum, so we get more intracellular calcium coming from that sarcoplasmic reticulum, and then it's also increasing this calcium to be pumped back in, so when we get relaxation. So all of this movement of calcium, remember calcium was responsible for excitation-contraction coupling because it releases the troponin, you get tropomyosin pulling that off, and so we can get contractions. We get enhanced actin-myosin interaction. So we increase cardiac muscle force, contractility, so that hard heartbeat, and we increase that velocity, so we increase that heart rate. So the two things going on here. Okay, so let's look back at this picture now. So now we're looking at, this would be the intrinsic rate of the heart, and we said that that was faster. Normally we got the brakes on because we have vagal tone, but now we are going to be closer to threshold, and we are going to move stuff faster. So we have increased the slope, so we've increased heart rate, and we've increased contractility. So beta blockers are drugs that block those beta adrenergic receptors. So they're beta antagonists. So we're going to slow heart rate with those types of drugs, and we can lower blood pressure. So that's where this all plugs in, and that's why you kind of have to have a good understanding of this. So recap. All right, so parasympathetic innervation, rest and digest. The neurotransmitter is acetylcholine. It's going to decrease heart rate by opening potassium channels. We're going to hyperpolarize those pacemaker cells further away from threshold. And this is what's normally at play because life is boring. Okay, so vagal tone of the heart is going to lower heart rate at rest about 75 beats per minute. Sympathetic nervous system, fight or flight, takes over during the 3 E's. Exercise, emergency, or excitement. Neurotransmitter is norepinephrine, or the hormones, remember, epinephrine and norepinephrine. It's going to increase heart rate and contractility. So we're going to get a harder heartbeat, more blood ejected by moving calcium. So it's kind of a recap of that. So get a good understanding of this slide. Okay, so just make sure you got this. To which organs would blood be distributed? I'm going to let you answer that one. So temperature also has an effect on heart rate and blood flow. And this one, you know, I'm always telling students, you can really sit there and try to memorize stuff. You have a body, so just sort of think about it. So it's the hypothalamus that's controlled body temperature, and it also communicates with the cardiac center and the vasomotor center. All right, so let's look at these two pictures. What do you think? So when you're cold, where is the blood going to go? Is it going to be sent to the skin? I don't know, how the tips of your fingers and your toes feel and the end of your nose feel when it's cold. When it's hot, what do you look like when you're hot and sweating? Okay, all the blood is at the surface, so you're going to be pink or reddish in appearance. Your skin's going to be hot to the touch, because wherever the blood goes, the heat goes. So yep, in cold temperatures, blood stays near the core. Warm temperatures, blood is distributed to the skin, and the heart rate is going to increase also, because we don't want to keep that hot blood by our sensitive organs, like the brain. So we're going to increase heart rate just to dissipate that heat, and probably you're hot because you're exercising. And then cold slows things down. A lot of times to slow down metabolism, like operating rooms are going to be very, very cold. So we have done this part of your study sheet. So we talked about sympathetic nervous system releases epinephrine, norepinephrine during the 3 E's, excitement, exercise, and emergency. It increases heart rate. It also increases contractility, which we're going to talk about in a minute. Contractility increases stroke volume. Parasympathetic nervous system, the neurotransmitter is acetylcholine. This system dominates most of the time, and that's what's responsible for vagal tone, because it's the vagus nerve, cranial nerve 10, lowers heart rate and cardiac output. Remember, we're trying to get to that equation. Heart rate times stroke volume equals cardiac output. Cardiac output times peripheral resistance equals blood pressure. So next, we're going to go to stroke volume control. So we talked about heart rate. So standard heart rate is 75 beats per minute. And we know whenever the heart rate increases, blood pressure increases. So stroke volume is that other component of cardiac output. Stroke volume is the amount of blood pumped in a single heartbeat, and we talked about this already. Usually it's given in mils, it can be given in liters, but a stroke volume is about 70 mils per beat. And so it's end diastolic volume minus end systolic volume. There's 3 factors that affect stroke volume. And so remember up here we have end diastolic volume. That's the volume when after ventricular filling. So now the heart is no longer going to be in diastole. Then we've got systole, so we eject. And so what's left in the ventricles is that end systolic volume. So remember that was the stroke volume. So we're talking about preload, contractility, and afterload. Preload and contractility, when they go up, cardiac output goes up. Afterload is the one pressure that's working against cardiac output and against stroke volume. And so we're going to look at these. So preload. So the definition of that is the degree of stretch of cardiac muscle cells before they contract. Okay, so if we increase preload, we're going to increase stroke volume, the amount being ejected. There's something called the Frank-Starling law of the heart. You can go ahead and read that, but I can sum it up in 4 words for you. More in equals more out. So what that means is the more blood that's going into the heart, so venous return, is going to increase the amount of blood going out. And that has to do with the length and tension relationship between those myosin heads, that thick filament, and the actin. When the heart is not stretched, so when the heart's at rest, it's not at optimal overlap for muscle shortening. And once again, I don't really care that you know that. The big thing is more in, more out. And here's my analogy. So I realize this is an old picture, but I don't know if you've ever been to a house that's an old-timey spring door. And so the idea is you walk through that door, it just has a spring that closes it and slams it behind you. you know, like if you're at your grandma's house and you just kind of want to sneak out, if I open this door just a little bit and I sneak myself out, that door is going to close kind of gently, right? If I fling that door open and let that spring slam it back, then she's going to hear me and I'm going to get busted, okay? So the most important factor for influencing preload is venous return. So the amount of blood flowing in, that's called venous return. If venous return goes up, preload goes up, because that's what we're talking about, the degree of stretch, that ventricular wall is going to stretch, and then the more blood is going to be ejected in that heartbeat. So we're going to get a stronger heartbeat. So slow heartbeat. So if there's a lot of time for ventricular filling, that can increase venous return. And then of course exercise. When we exercise, we're using that skeletal muscle pump, we're using that respiratory pump, we are going to get increased preload. Increased venous return stretches those ventricles and increases that contraction force. And so we're going to get more blood ejected per beat, increase our stroke volume. So body position has an effect on venous return and therefore stroke volume. So when someone stands in one place, once again, we've got gravity working against us, and standing, we're not really using that muscle pump. So standing is going to decrease that venous return. When someone is laying down, just like in that video we watched, then blood is evenly distributed. That's going to increase central venous pressure, so increase our venous return, increases our end diastolic volume, and increases stroke volume. Okay, so think about it. So what effect do you think exercise has on venous return and stroke volume? Hopefully you got that right. So the second thing that's going to increase stroke volume is contractility. And so that's the contractile strength at a given preload. So sympathetic nervous system opens those calcium channels, increases contractility, therefore increasing stroke volume. So we got closer to threshold because the calcium came in, but the fact that we are increasing the speed of these calcium pumps, so we are moving calcium faster, and we've got that great preload, so we are going to increase, like I said, not only the rate, but that contractility. So we're going to get a stronger heartbeat, so more blood is going to be ejected. The one thing that works against stroke volume is called afterload. And so think preload stuff going in, afterload has to do with blood leaving the ventricles. And so it's fluid, remember, and fluid moves only from greater pressure to lesser pressure. So those ventricles have to create a pressure that's greater than the pressure in the aorta. And so things that increase afterload are hypertension, so systemic high blood pressure, and valvular stenosis. These two things are going to increase the afterload. Hypertension often occurs because of that atherosclerosis. So here it's showing you a nice open vessel. Okay, so that'd be low afterload. And then as people age, they get these plaque deposits. And we know if we have a smaller lumen size, that increases the blood pressure. So that means that ventricle, that left ventricle, has to work even harder to get the blood to move from the left ventricle to the aorta. And this one's really occluded. This is a whole bunch of plaque and a very small lumen, so that's a really high afterload. So increased afterload is the one thing that will decrease stroke volume and cardiac output. That's why hypertension, and we talked about valvular stenosis, are bad. And so these are those semilunar valves. In particular, we're talking about the aortic valve. And when they are healthy, they just open nice and wide. When we've got a stenotic valve or valvular stenosis, that means they're probably calcified, they're stiff, they were damaged by rheumatic fever, just calcium deposits with age. Then this opening gets smaller, those little flaps become non-compliant. And so the heart has to work harder against this afterload. So valvular stenosis and hypertension are the two things that increase afterload, and that's going to decrease stroke volume and cardiac output. So recap. So 3 factors that affect stroke volume. Preload, that's more end diastolic volume, so more venous return. So think like that spring, like grandma's porch. If preload is high, stroke volumes is high. So more in, more out. And increased stroke volume, we're going to get increased cardiac output, increased blood pressure. Contractility is that force generated during ventricular contraction. If contractility is high, our pump is working really strong, so that's going to increase stroke volume. So sympathetic innervation, so norepinephrine or epinephrine, is going to increase contractility. That's going to increase stroke volume. We get an increase in blood pressure. Afterload is the one thing working against stroke volume. Afterload, think bad. That's the pressure against which the heart must work to eject the blood. If afterload is high, stroke volume is low, that's going to lower our cardiac output. So things that increase afterload: hypertension, atherosclerosis, so the forming of that plaque inside the vessels because that narrows the lumen and increases peripheral resistance. And then aortic stenosis, those are those little flaps that don't open. Those two things, or sorry, hey, I can count. Those three things increase afterload. So here it is in this picture. So exercise increases activity of the respiratory pump and the muscular pump. We're going to get increased sympathetic venoconstriction to increase that blood flow, increased venous return, increased end diastolic volume, increased stroke volume, increased cardiac output. Decreased blood pressure, we have to respond. So increased sympathetic activity, we get epinephrine, we're going to increase contractility of the cardiac muscle. That is going to mean less blood's going to be left after that contraction because it beat harder. That's going to increase the stroke volume, increase cardiac output. We're also going to increase heart rate. So just remember, cardiac output is heart rate times stroke volume. Cardiac output times peripheral resistance increases blood pressure. So anything that increases cardiac output will increase blood pressure. So that was short-term control. Short-term is always going to be neural control. So our long-term control of blood pressure is going to be through controlling blood volume. And the organ responsible for that is the kidneys. The kidneys filter blood and make urine. And by controlling our urine output, so how much volume we have, that's how we control our blood volume. And we talked a little bit about this with endocrine, so hopefully this is kind of a review for you. We're just kind of hearing it again. Blood volume, remember, on average is about 5 liters for an adult, 4 to 5 for females, 5 to 6 for males. This is the key, these three things. Remember, higher blood volume means higher blood pressure. Lower blood volume means lower blood pressure. So the rule to remember is water volume always follows salt. Yes, here it is. Okay, we've talked about this. Let's start over here. If there's low blood pressure and we are salty, so we're dehydrated, so high blood electrolyte concentration, we know that the posterior pituitary is going to be told by the hypothalamus to release anti-diuretic hormone. So we're anti-diuresis. That means we're not going to pee. So we're going to reabsorb water, so that's going to increase our blood volume, and that should increase our blood pressure. If we have low blood sodium levels, low blood volume, then we're going to get, the kidneys are going to release renin. So from renin leads to the production of angiotensin 2. We're going to watch a video in just a second. Angiotensin 2 causes vasoconstriction. It also causes the release of aldosterone from the adrenal cortex. Aldosterone tells the kidneys to reabsorb sodium, and we know that water follows salt, so we're going to increase blood volume, increase blood pressure. So we've got long-term control through blood volume to raise blood pressure, and angiotensin. Angio means vessel, tension, think tension, causes vasoconstriction. So remember, that's a really quick, we can close off that lumen, vasoconstriction, and raise blood pressure. So both those things, increasing blood volume and vasoconstriction, we can increase blood pressure. We only have one hormone that lowers blood pressure, ANP, and a really easy way to remember this is ANP is going to make you pee. So atrial natriuretic peptide. This is going to be secreted by the atria. The cells of the right atrium are going to release ANP when there's really high venous return. So when they get stretched, That's how they detect high blood volume. They release ANP. That's going to make sure that sodium gets excreted and water gets excreted. So that's going to lower the blood volume and restore blood pressure. So ADH, renin, angiotensin, aldosterone all raise blood pressure by raising blood volume. The only thing that lowers it is ANP because it's going to make you pee, and that's going to lower blood volume and lower blood pressure. Here, let's go ahead and watch this.
In this video, we will discuss the renin-angiotensin-aldosterone system. And before getting into all the complex stuff, let's have an overview of this system. So whenever your blood pressure falls, known as hypotension, the kidneys are able to sense it and they activate the renin-angiotensin-aldosterone system, which acts on kidney as well as the blood vessels to restore the blood pressure to the normal. Most of you know the kidneys are supplied by a set of renal arteries, which supply almost 20 to 25% of whole cardiac output to kidneys. This blood reaches the glomeruli through the afferent arterioles.
These are the little nephrons.
And leaves the glomeruli through the efferent arterioles. These cells you see are the juxtaglomerular cells. The word juxta means near, hence these cells are located near the glomerulus. These cells secrete a substance known as prorenin, and hypotension is a main stimulator of converting prorenin into renin. Renin is an enzyme which acts on angiotensinogen. The word angio means vessels. The word tensinogen means a substance which constricts the vessels. It is a plasma protein which is synthesized in the liver. Renin converts angiotensinogen into angiotensin 1. The next step takes place in the lungs when the enzyme angiotensin converting enzyme acts on angiotensin 1 and converts it into angiotensin 2. The angiotensin 2 is a powerful vasoconstrictor which mediates the effects of renin-angiotensin-aldosterone system. Let's look at the effects of angiotensin 2 on blood vessels. As I said, angiotensin 2 is a very potent vasoconstrictor. It constricts both the arteries as well as the veins. The constriction of the arteries leads to a total peripheral resistance increase, and the constriction of veins lead to increase in the venous return to the heart. Both these mechanisms increase the blood pressure of the person. This effect is rapid and takes a few minutes. Now let's look at the effects of angiotensin 2 on the kidneys. These effects are slow and take a few days to have their maximum effect. Angiotensin 2 acts on kidney in two ways. The first is the direct mechanism. As most of you know, the GFR of the kidney is directly proportional to the blood flow through the kidneys. The blood enters the glomeruli through the afferent arterioles, and angiotensin 2, being a powerful vasoconstrictor, constricts these afferent arterioles mainly and decreases the blood flow through the kidneys. This results in a decrease in the GFR of the kidney, which results in a decrease in the urine output through the kidney. Now second is the indirect effect, in which the angiotensin 2 acts on the adrenal gland and releases aldosterone. Aldosterone in turn acts on the kidney and increases the sodium reabsorption as well as the water reabsorption. So we have a decreased urine output, increase in the water reabsorption, and increase in the sodium reabsorption. All these effects lead to an increase in the extracellular fluid of the body, an increase in the capillary pressure, and a long-term increase in the arterial pressure. So to summarize, let's suppose a person gets stabbed and he loses a lot of blood. This will lead to a decrease in the blood pressure of the person known as hypotension, which is a potent trigger of activation of renin-angiotensin-aldosterone system. The RAAS further acts on the blood vessels as well as the kidneys and normalizes the blood pressure. So this was all about the renin-angiotensin-aldosterone system.
So let's unpack that video a little bit. We will go into the part, I know you kind of went into the GFR and urine output that way. We will add that GFR part in the glomerulus in Unit 3. But let's kind of look at what he was talking about at the end. So hypovolemia, so that's when someone has low blood volume. Things that can cause this, clearly he used one being stabbed, so bleeding, that'll do it. It could just be just general dehydration, so not taking in enough fluid. If someone vomits, that they lose a lot of fluid that way, so it could happen that way. Severe burns also cause a loss of fluid, and then diuretics, so drugs. So you get a decrease in blood pressure and volume. So the endocrine mechanism, we talked about ADH, so antidiuretic hormone. We're going to get renin. Angiotensin 2 is that potent vasoconstrictor. And we get aldosterone and EPO release. Okay, so antidiuretic, we're going to reabsorb water. Angiotensin, aldosterone, we get reabsorption of sodium and water. Erythropoietin, that kind of makes sense. If someone has low blood volume, like they lost blood, we kind of need to restore those red blood cells. But all of these, the purpose of it is to increase blood volume, which will then, homeostasis will be restored. Pop down here, so that neural mechanism, just to review. If there's decreased blood volume, there's going to be decreased blood pressure. Those baroreceptors are going to start screaming. There's also chemoreceptors that can tell things are going on. Going to talk to the cardiovascular center. So we're going to get general sympathetic activation, release of norepinephrine and epinephrine. So the whole point, what we can do short term, we can increase cardiac output by increasing heart rate and contractility. And then we know we can do peripheral vasoconstriction. So increase blood pressure, and then we can release the blood from the veins. So we're going to venoconstriction. So we're going to get some of that blood that we had in reserve. So that's all to restore homeostasis. So there's a homeostatic response to loss of blood volume. So now we've done this whole top part. So we have long-term adjustment of blood pressure through the kidneys, through volume control. ADH's other name, remember from endocrine, is called vasopressin. So we also get constriction of those blood vessels. It's going to increase water absorption. You got the renin, angiotensin, aldosterone system. That's going to increase sodium absorption. AMP is the only antagonist to all of this. So it basically, we're going to get, it's going to inhibit aldosterone release and ADH. So we're going to lower that blood volume and lower blood pressure. So ANP makes you pee, and it's the only thing we have, the only hormone we have that's going to lower blood volume and blood pressure. So if we get increased blood volume, we're going to increase in blood pressure. So hopefully you've got that top part. Just a little bit more to go. So down here, so 3 factors to peripheral resistance. So opposition to blood flow, because we've got blood pressure equals cardiac output, so that's heart rate times stroke volume, times peripheral resistance. Things that increase peripheral resistance. So blood vessel length. To be honest, it's pretty constant, unless someone is growing or unless they gain weight. We're going to talk about hypertension in just a minute, and one of those factors is obesity. So when you gain weight, you've got to then supply that fat with vessels. So often blood pressure will go up if a person's weight is high. Blood viscosity, so think about, sort of sucking something really thick through a straw. Usually that's constant, unless we have polycythemia. So polycythemia vera we talked about. So we have an increased red blood cells. That would increase the viscosity and blood pressure. By far, the biggest influence, oh look, I put it in blue and a bunch of stars by it, is going to be that blood vessel diameter. So vasoconstriction, vasodilation. All right, in case you're still not quite clear on that vasoconstriction and how it increases blood pressure, hopefully you had a childhood where you played with a hose before. If not, go play with the hose today. So if you just have the hose on, you know that the water's not going to go very far. But if you want to shoot your brother or sister or your friend, you're going to put your thumb over the opening of that hose, and then it's going to really shoot out at them. And so that's basically how that works. So vasoconstriction is going to increase blood pressure. If you leave it open, that's going to lower blood pressure. And the other thing that factors in peripheral resistance is what's called vessel compliance. As people age, their arteries get stiff. And so that stiffening of arteries, they lose that elasticity. That's called arteriosclerosis. Yeah. Okay, I guess I should have just clicked. My bad. All right, so vasoconstriction. So this is constricted artery. It's going to increase peripheral resistance. which increases blood pressure. Atherosclerosis, that's that fatty plaque buildup. We know that that makes that lumen size small, and so we're going to increase peripheral resistance and increase blood pressure. Arteriosclerosis, that's that loss of elasticity that increases peripheral resistance and blood pressure. So it's kind of normal as people age for their blood pressure to get higher. Vasodilation, so that's when we open them nice and wide, that's going to lower peripheral resistance and lower blood pressure. And like I said, blood vessel length, that's not something we can just control, but this is the correlation with obesity and hypertension. So increased blood vessel length, increased peripheral resistance, and BP. Children have less resistance, they have lower blood pressure. More vessels, more friction. Okay, so we kind of finished this. Hopefully with the questions, it's kind of helped you, but just study and understand this. If you need me, I am here for you. So ask me questions. All right, so this is just another view of that. I'm just going to leave this for you. I think we kind of went over it. But this is showing you all the things we talked about. So increased body size, blood vessel length, dehydration, high hematocrit, increased blood viscosity, and then most important, that vessel diameter is going to increase peripheral resistance. And then these are all the things that are going to increase cardiac output. So mean arterial pressure, remember that is that basically that average amount of pressure that's in the vessels to deliver blood to the tissues, and it is directly proportional to blood pressure. All right, so body position and heart rate. So think about it, we kind of talked about this. When you are laying down, you've got increased end-diastolic volume and increased stroke volume. And think about when you stand up really quickly. So when you stand up, just like in that first video we watched, sort of like a water bottle, we know that there's going to be a drop in pressure. So if MAP drops really low, we get that reflex, we get vasoconstriction, increase in cardiac output, and blood pressure. So like I said, a lot of this happens when standing. If you've ever gotten up out of bed really, really quickly and you sort of felt that little head rush, that's because you got up faster than your baroreceptor reflex could take effect. So if you want to feel this, so next time, tomorrow morning when you get out of bed, put your fingers, feel your pulse in your carotid artery, be nice and slow because you're laying down. And then when you pop up out of bed, your heart rate's going to increase, your heart's going to beat harder, so increased contractility, and you can't feel your vasoconstriction, but that's what's going to occur. Baroreceptors are ineffective if you're standing in place for a really long time. You know, sometimes people get lightheaded if they don't move around. So, hypotension, that is chronically low blood pressure. So like I said, we've all sort of felt that little head rush popping up out of bed, but if someone's blood pressure is low, they're going to feel kind of tired, they may feel dizzy, and they may actually faint because that's the body's way of fixing it. Because if somebody faints, then they lay down, that's going to increase venous return and stroke volume. But it's defined as systolic pressure below 90 and or diastolic pressure below 60. A common thing is orthostatic hypotension, and that's that drop in pressure after sudden standing. So that dizziness, lightheadedness, fainting. So they recommend definitely as people age, for your older patients, get out of bed, get up slowly. And this just means that baroreceptor reflex blood pressure regulation is not occurring quickly enough. I think we've probably all felt that. It's not just old people. So we need to talk about systemic hypertension, and then I'm going to connect that to congestive heart failure. So systemic hypertension, we are talking about in the vessels going to the body. So hyper means above, so high blood pressure. So it's over 140 over 90 millimeters of mercury is equal to or over is systemic hypertension. So it's estimated that 1 in 3 adults in the United States has hypertension, and they even think like less than half have it under control. It is a silent killer because there really aren't any symptoms. Most people are asymptomatic for hypertension. They can't feel it. So unless they're getting checkups, unless they're monitoring it, often it goes unnoticed. Normal blood pressure, its target is 120 over 80. I don't know why that's in there. So 120 over 80, that's the target. Strangely enough, so primary or central hypertension, there's actually no one underlying cause. because you can't see me, but I turned 40 and now I have hypertension. Well, that was a long time ago. If you look at me though, I don't have any of these risk factors. So sometimes it's just idiopathic. So when I walked in at 40, I had hypertension. They said, yep, you're going on drugs for the rest of your life. Other people, there are some risk factors. So someone's pre-hypertension, they might say, okay, you might want to lose some weight. So if someone is overweight, they've increased their peripheral resistance because they've increased vessel length. Diet, high salt, high fat diets. So the high salt leads to high blood volume. So that's going to increase blood pressure. High fat diet is correlated with atherosclerosis. So we know that that too is going to increase peripheral resistance. When people are stressed, they get a whole lot of extra, epinephrine and norepinephrine. So that can increase it. Smoking also has an effect on the cardiovascular system. That too can cause hypertension. And all of these things occur with age. So options, so if somebody comes in, like I said, and they have all these risk factors, and we say, okay, adjust your diet, lose some weight, do some yoga, stop smoking. So they can try lifestyle changes to reduce that. But if not, then it has to be controlled through medication. And that requires patient compliance. They have to refill their medications, they have to take them, and that does not always occur. All right, so I want to talk about why is hypertension a silent killer? It's because it has an effect on the heart. And so chronic hypertension leads to left side heart failure. So think the heart has to work harder. So let's see. So now if somebody has hypertension, we know that that increases afterload, right? So that means that left ventricle has to work harder to eject the blood. So if it has to work harder, since it is a muscle, that myocardium is going to grow. It's going to hypertrophy. So just like if you go to the gym, you're going to lift weights, your muscle's going to get big. So chronic hypertension, that heart has to increase, so you get hypertrophy. The thing is, cardiac muscle is different, so that's not a good thing. So what happens to the wall of the ventricles is they end up getting flabby and they end up getting weaker. So what happens then? So now the right side of the heart is fine. This side of the heart isn't doing so good. So remember, we got veins go to the right side, go to the lungs, and then from the lungs it goes to that left side. So this right side is fine. So pulmonary venous return is coming into that left side, but this left side is not, it's weaker. So it's pumping less blood than the right side. So where's the blood gonna go? So the only place it can go, it's going to back up. And so it's going to back up into the lungs. When it backs up into the lungs, okay, that's going to cause pulmonary hypertension. So pulmonary always means lung. So it's high blood pressure in the pulmonary arteries. And so that's a pressure greater than 25 millimeters of mercury. And I told you the pulmonary circuit is a much lower pressure circuit. Okay, so now we've got hypertension in the lungs. So now we have increased afterload on that right side of the heart. So pulmonary hypertension leads to right side heart failure. You can also get pulmonary hypertension from pulmonary disease as well. So the same thing's going to happen on the right side that happened on the left side. So initially you're going to get hypertrophy because we have the heart still has to work. It's working harder because that increased afterload. So we get cardiac muscle hypertrophy, okay? But then I said it's not going to stay there. Then that wall is going to get flabby and it's actually going to get weaker. All right, so think about it. So now we've got venous return, so blood's coming into that right side, but now that right ventricle can't keep up, okay? So venous return is greater than cardiac output of this right ventricle because we've weakened it. Okay, so where is the blood going to go? Right, the only place it can go is it can back up into the systemic circulation. So it's just going to back up to the veins. Okay, and so that's how congestive heart failure occurs. It's a weakness of the heart that leads to a buildup of fluid in the lungs and surrounding body tissues. So remember, we had a normal heart. We had an enlarged heart because of hypertrophy. All right, so we get excess fluid around the lungs because we had that left side failure. We're going to get swollen. We have the excess fluid now backing up to systemic circuit. So we get swollen, cyanotic, that means blue, because it's deoxygenated blood. It's not returning because that heart is too weak. And so trouble sleeping, they have to sleep upright because of this increased fluid in the lungs. We've got swelling, particularly in the legs. And so they're going to probably be put on all kinds of drugs. But one of the big things, a water pill, maybe you've heard of that, to try to get rid of this excess fluid. But that is really congestive heart failure. And that is why hypertension is a silent killer. It wears out the heart. Okay, I hope that all made sense to you, and hopefully the questions embedded in here have helped you. Once again, I'm here for you. Do study your Quizlets. You have an awesome day.